channel Know Your Calling. So basically, Know Your Calling is a platform for all the budding aspirants who are in confusion for which branch to choose. So today's branch of discussion is emergency medicine, and for that we have our special guest Dr. Ravi Teja Kethavath sir, who has done his MD emergency medicine from NTR University, has an MBA credited post MD DNB degree as well, is right now a consultant and head of emergency department at the ANU Institute of Cardiac and Neurosciences. Is also a flight physician at International Critical Care Air Transfer Team. And adding to that, cherry on the top, he has also a degree in MBA in hospital management. So very, very warm welcome, sir.
Thank you, Dr. Aishi. Glad to meet you all.
Okay, sir. So, about emergency medicine, sir, whenever I hear this word emergency medicine, there is always this ambulance siren that rings in my mind. So, can you just give an insight about and a general introduction about the branch emergency medicine?
Yes, Dr. Aishi. The introduction of the branch is very much needed because most of the doctors, junior doctors or senior doctors, it is not very much well known unless until they are working in a hospital where this department actually exists. Not the name, the department actually exists. It started in 2009 in India, started in AIMS, New Delhi. In 2012, it came to many other states like Tamil Nadu, Kerala, Andhra Pradesh, South India I'm talking. North India I'm not specific about the years and the states. So regarding this, the simply to tell emergency medicine is anyone, anytime, anything. So we'll treat anyone who is coming with any type of pain. It is not like this is not my domain, I can't see you. After the OP closes of the hospital, every kind of patient, irrespective of the sex, age, diagnosis, will be coming to the hospital. Emergency medicine is also having a name called face of the hospital. So what the person sees in the hospital will be, he'll be having the first impression in this emergency medicine department. The department name is Emergency Medicine Department, but the place we work is known as Emergency Room. We'll call it ER. So here the equipment, all the beds will be equipped with all the monitors, whatever the patient might come. It might be a disaster, it might be a pediatric emergency. A baby can come with croup, a person can come with a foreign body eye, a delivery mother can come with the seizures, an orthopedic trauma, head injury, a case of stroke, a case of heart attack, anything might come, we are ready to stabilize the patient, irrespective of the department.
Okay, sir. Yes. And so, sir, starting from the journey itself, so any be it any branch, the residency period is always going to be hectic. And
Yes.
for emergency medicine per se, it is going to be more hectic than any other branch in comparison. So, how will you describe your residency period and your life as a resident, especially in the first year of residency?
Actually, to describe the resident of an emergency medicine, you have to be totally occupied with the department. You won't be having any personal life. If you are having any family, friends, you have to leave everything because on paper the duty hours will be. I'm talking about the average timings of all the departments in India. Average timings is 12 hours on paper, but for a resident to leave the department will be happening about 15 to 16 hours. If there is an academic program attached to it, mostly 3 days per week, it will be up to 17 hours or 18 hours. This is an average time. So the resident will go to the hostel only to sleep. So he can't have his own family time, friends time, or going to a movie or anything. So he has to be very much dedicated to the department. Otherwise, he can't enjoy the work. People has to really love it. And coming to the department, the monitoring and all, the departments will be very strict. Whatever department you take, it will be very strict. So people will be like cursing the seniors and the assistant professor. Why this chalo, why this guy is so much strict? Is he having any anger on me? No, because The patients will come. Some things you have to do, otherwise the patient will die. Some things you shouldn't do, otherwise the patient will die. So there is a thin margin between to do and not to do. So that margin the resident has to understand in his residency. Not even emergency department, any resident will learn in these 3 years. After these 3 years, no one will come to teach. So normal residency, it will take around 1 year or 1.5 year to manage the patients and all. In emergency department, they'll train and teach everything within 6 months. So after 6 months, the resident is able to do all the procedures in the emergency room. And coming to the duty, uh, it's not only regarding the patients. They'll be adding of administration also. You have to administrate also the your department. Otherwise, no one will take care about you. You will be responsible for the patient from the ramp until the patient will be shifted to a ward or ICU. Resident will be blamed if anything happens. So you have to see all the things. You can't tell the sister is not working, that security guards left. Everything will be coming on to the resident. Mostly the first year residents, the scapegoats.
Yes. Yes, sir. So we have learned about the adversities. So do you think any is a specific cons of emergency medicine and you felt that in the residency period and also now?
Actually, not to boast about myself, I'll tell some cons about the department, but I didn't feel anything personally because I love the department. If someone will tell this, if I am not becoming an ENT surgeon, I would probably become a other like gynecologist or other things, dermatologist. For me, if you ask me that question, I don't know what I will do except for this department. I don't know what department I'll fit in, what will I do. I have no clue at all. So, coming to the cons, which other people regularly see, is hectic work timings.
Mm.
It will be around 15 hours easily per day. And the resident won't be having a time to even sit and write. Yeah, we'll go to the bedside, we'll touch the patient, treat the patient, do any procedures. We'll write the patient initial assessment nearby the patient, everything. Meanwhile, doing resuscitation for a patient, another patient will enter. We don't know when it will become busy. So, as soon as possible, we stabilize the case. We'll try to shift the patient to that specific ward or ICU, or even we'll discharge the patient also from emergency room. And coming to the strictness, as I've already said, people will be very stringent in the department. Not even the department, other departments will enter into the emergency room. Medicine professors, surgery professors, they'll directly talk and they'll directly scold because they know something. Because the residents can't know everything. Everyone is in the learning period, so they has to get blame from all the departments if they are not doing good things. And there should be a rapport. Emergency treatment is not just a one man team. It is already all persons should involve. My team will include a security. From security, receptionist, myself, I have a paramedic, technician, nurse, ward boys. Everyone should work as a team to resuscitate one single patient. If any one person is also a defect, the whole process will go wrong. And the other cons is people will have sleep disturbances sometimes because on a normal basis in my department I used to work for day duties for straight 15 days, and next 15 days will be night duties. In some other departments, 1 week day duties and 1 week night duties. For 365 days, 3 years, 15 hours, you will be on floor. Then where will you get time to watch movies, go with friends? You will not be having any of the time. Even weekly one off will be given for the residents, and that will be half consumed with the academic program and other half for taking rest. A person will not get an idea to roam outside while working in the department.
That is, we have learned a lot about the adversity, sir. So, on a positive note and flipping the coin, what are the things you loved about it, and what are the things you still love about the branch?
During my internship, I have learned the casualty because my hospital is not having an emergency department at that time. So I'm very much interested in casualty because all kinds of cases comes, and will basically the feel of the doctor will come when he is able to treat anything, and finally he saves a life in front of him within minutes or hours. So that one I liked in casualty, and I followed the same in emergency room. So the satisfaction will be at the most for emergency physicians. There are several articles who which study about burnouts, lifespan, stress. Everything will be highest for emergency medicine, and the satisfaction will be more over these three things. So you will be never be satisfied after treating a case. Some people will come to me within minutes. If I am not diagnosing within that 1 minute or 10 seconds, the patient might lose his life. And after the heart stops, it might be coming back or the patient might die. I may not guarantee the resuscitation. The thing is, treating a stable patient is easy, and after a heart attack is easy. Even ACLS, CPR, cardiac resuscitation, intubation, everything easy. There is a thin line between this that 1 2 minutes which we want try to prevent that arrest. That is the most difficult and tricky part. For that, the stringent training will be given by our teachers. And a satisfaction is some departments will come to us. You will be looked as a hero in your hospital because you can treat any case. You will have answer for everything for emergency. If some obstetric case comes, is suddenly the patient BP is high, she comes with a headache. Suddenly, when the obstetric PC is there with the patient is having a seizures, eclampsia, they will be helpless because they will be treating only the obstetric part, but the seizures and the intubation we will take care of. So we will go as a rescue for any orthopedic case. The cases like ankle fracture, we will give local anesthesia. There is no need of anesthesia people to come into emergency room. We will give the local blocks, and procedural sedation, which will be given for the reducing of the dislocations. Everything which will be done in my department will be done by the emergency people only. We don't call other departments for help. You will get that
Yes.
satisfaction.
Yes. Okay, sir. So for whenever I did emergency medicine duty during internship or the casualty duty, I went all chaotic and gaga over all the duties. Honestly, but I feel you are very calm for a person who is a MD emergency medicine. So what do you feel is the personality type who should choose emergency medicine or who should reject the branch?
Actually, there is one saying: the people won't choose emergency medicine. The department chooses the people. There will be some type of calling, some type of intuition, initiation, some type of like a some people they have met some people in a conference, and this KYC channel, this might be an introduction to some new people to know about the department. So person should not be weak. If you ask me which is the main dominant thing is mental health, primarily mental health. Some girls will usually come to me and ask during their internship period, can I do this? I'm not that much strong. No, that is not like that. Physical energy you can increase, but mental strength, it is very difficult to increase. So the person has to be physically and mentally strong, and he should be passionate for the department. And I'll see the people in only two categories: people who work, people who don't work. Even so many people don't like my department because of that hectic duties. Juniors, they will be used to scold me during my seniorship and all. But I tell them, at least act that you are doing good. At least do that. If you don't like also, try to love the work. Eventually you will surely love the work. So in this plane, the person has to be very much disciplined. Without discipline, without that empathy, I'll tell my residents, my juniors, that treat the person as you know the person. Some like treat the person as you someone has recommended to you. Don't leave a person like he is some unknown, he is some stranger. If you have some empathy, you will treat good, because only you are going to treat him for only just hours, 2 to 4 hours only you are going to treat. If you are not able to concentrate for the 2 hours, how are you expecting you will become a good doctor after residency? Then you have to work for hours, days, and years together. Some people will follow you. You can't be that good person or a good doctor if you are not able to concentrate for specific 2 hours. So the weak hearted persons who will cry easily or who want to like discontinue easily, many of the seats have been left in emergency medicine department. This is the highest. I don't have the exact number. People will join, people will see for 1 or 2 months, due to unable to cope up with the stress hours or scoldings, people will leave. That will be becoming the stress factor for the colleagues, for the seniors and juniors, because most of the departments are having only two PGs per year. So either two PGs will be first years. They won't be working at the full potential of the learning. They should need some support. Other two people will be in peripherals, and other two people will be in exam going preparation, thesis work, and all. So the whole crowd of the department, if the census is 50 or so, you have to see 25 patients. 25 only emergency patients. You
Yes.
need to resist it. So you have to be mentally very, very strong. Physical strength comes afterwards. If you are not mentally strong, or if you are arrogant, this department is not for you. If you are arrogant, they will show you the hell, the department professors and all. You can't ever overcome them. You have to mold, or you have to leave the department. So beware on this.
Okay, sir. So while we complete the residency period and then we enter into the real world, which already sucks. So what about the settlement? So kind of in any surgical branch, there is going to be a long learning curve, but not in the case of emergency medicine. Either you learn it in the 3 years of period, and after that you are almost ready for any kind of job you want, whether it be it in any government hospital or corporate hospital. And so, sir, what do you think about it? That is the settlement issue in government versus corporate, in big cities versus small cities, in tier one cities, or setting up a own emergency care center.
One thing, after the residency, the opportunities are vast. If you are going out immediately after the duty, and the results will take 1 or 2 months according to the university. Before the results only, you will be recruited. People will call you. I got calls from even my second year from the
Mm,
places which I don't know at all. So the recruitment is fast, but
mm,
you have to think which place you are going and what you have to do. I have called to some other places just to see like a general physician, seeing an OP, discharging the patients, managing the ICU patients. I can do that, but that is not what I meant for all these 3 years. If I'm not going to an established emergency department, or a place which is potential development for an emergency department which I can develop, I'll forget things. If I don't see an ECG for a month, I'll forget. ECG should be seen regularly. Likewise, procedures also. I need to have some ultrasound mission, ABC mission nearby. I need to have monitors, the wires, everything, the equipment. The half of the emergency medicine will be filled up with equipment, gadgets, everything. These are needed for the physician to treat the patient quickly as possible. So the opportunities are good outside. So better choose where you can grow more, where you can treat more, and where your need is there. Suppose, for example, you are called upon a city where the department, some departments are not there. Like if nephrology is not there, cardiology is not there,
mm.
those set of patients won't come to you. Even though those set of patients are coming to you, you have to finally refer the cases. You can't even follow up, you can't even discuss with the super specialist regarding the care of the patient. So finally you have to go into a multi-specialty hospital only. Either it can be government or a private, and either medical college or a government medical college or a private medical college where there is established department, or you have to develop a department. And most of the times when the residents are relieved, they pass, they will go to a place and they develop a department, because there is no emergency department in max hospitals, most of the hospitals. So the people who are trained under us will go to a new place, will set up a department and follow the same protocols, which the other hospitals don't know. They will see the department running and they'll then know about the emergency physician.
Yes, sir. So there is something in your CV that is flight physician. That is something I have heard very little of, and I'm sure our viewers as also don't have any insight about it, sir. So can you talk about it? What is a flight physician and how it works, and how can you apply for it?
Flight physician, or you can call as the flying doctors or aeromedical commandos. These are the doctors who can treat a patient via flight in the air ambulances, via the travel. The duty of this particular doctors is to they'll shift the patient from bed to bed. If I'm going at a hospital in Delhi, the patient has to shift from Delhi to Chennai, whatever the reason, whatever the patient. Here also there is no age bar or diagnosis bar. We can shift any kind of patients. We'll first go to the hospital itself. We'll assess the patient, we'll assess the patient's condition is good to fly or not. We'll assess the things that are needed for a patient. If a patient is having a severe pulmonary embolism or a cardio CCF, cardiac shock or failure, there has to be needed a ECMO support. If there is ECMO support is not there in my flight, so I can't transfer this kind of patient. If I'm transferring a comatose patient, I need to get a intubation set ready. So the things which has to be needed for that patient, everything should be equipped. And this doctor will be accompanied with a trained paramedic, flying paramedic. These will be flying more than the doctors, because doctors will be positioned at different cities. For suppose I am positioned at Andhra Pradesh or coastal Andhra Pradesh. If any case is going from here to any other state, so I have will be a call. I have a call. The paramedics will be of 5 or 6 persons affiliated to that company. They will be continuously on that same job. So I'll assess the patient. I'll then transfer the patient files history to the main medical team, medical directors. Medical directors are the person who will sit in front of the computer and they will guide us to give any medical treatment. They'll guide us to into the flying procedure and all, because we have practiced only in the hospital on ground at sea level. During the flight, there is many changes in the physiology, normal physiology. There is many change of laws, Boyle's law, everything will come into place and the patient can go bad. So we have to be trained. There is a 1 year fellowship in this one, flying aviation medicine. So this will be done with the company I have joined in. The company is ICAT. It is positioned mainly in Bangalore and Hyderabad. It is having bases all the states in India. And entry to this is any MD or DNB in general medicine, anesthesia, emergency medicine, who are trained in this, who are well versed with the procedures, they can go. And for some special condition, if I want to shift a neonate, a neonatologist will come with an incubator in the flight. If I want to shift an ECMO case, CTVS surgeon with the ECMO team, they will come to the patient, they'll initiate an ECMO, they'll transfer the patient to the needed destination. And COVID cases, they will come with a COVID pod, isolation pod. Patient will be shifted in the isolation pod. This is my self interest, so I have joined into this.
Yes, and it quite looks interesting also, sir. And so going on to the survival aspects, and what is the core of everything we do in life, that is the monetary aspect. So what do you think average amount of money that any emergency physician earns?
So here there is a glitch. If you compare with any other department in any other hospital, that specific hospital, emergency physician will earn approximately like 80% more, 80% or almost 2x, double the amount of any other surgeon, physician. I'm talking about the primary specialties. But
Hmm.
the thing is that emergency physician will work for 8 to 9 hours or a shift basis. And
Hmm.
other time he can't go freelancing. He
Hmm.
won't see an OP, but his salary is 2x of the person normal primary specialty salary, but the salary is fixed. It will be good in the first year. But the physician or a surgeon or an orthopedician who is having half the salary of the emergency physician in the hospital, they will see one shift of the patients in the morning time and they can go freelancing. They can see individual patients in other hospital. They will be connected to multiple hospitals. They can have their own clinic. They can post their own cases into other hospitals. Their money is according to their work. It's proportional to the work and contacts they are having. So initially it will be double, but it will stay at that point only for prolonged period. There, the money coming from outside this shift is little bit low
Okay.
because the person will be doing the emergency shift and coming to home, he'll be vexed. He'll take some rest at the home.
Yeah. So, sir, as Aristotle rightly said, that the end of labor is to gain leisure. So, how do you manage your free time as a emergency physician? So, it is going to be very less in residency. That is a universal accepted statement. But we have to gain some time for leisure in our after the residency. So, how do you manage the free time for your family? And for the other things you kind of have hobbies for?
Very nice question. Many people will ask me this. It depends actually. When you are heading a department, when you are in charge, if the person newly passed out, he joined into a senior residentship, into a new hospital, into a new private hospital or government medical college, he has to monitor everything 24/7. At that time, even though the shift is over, he will be getting calls.
Hmm.
In the other aspect, if the person is joining an already established department, or a new medium sized corporate hospital, he will do from 9 to 5 shifts if other emergency physicians are not there. Or if three people are joining into the department, they will be having 6 and 12-hour shifts. After that 6-hour shifts, you are completely free from the department, clinical issues. That's what I like in emergency department. I'll think about the patient very much deeply. I'm very much concerned about the patient until he is in my department. The patient is moving out, like I will be totally relieved from that thinking. I should concentrate on the next patient. And after my shift ends, there is completely coming off from the duty. No one will disturb me. It depends on the hospitals, that the kind you manage. The same emergency physician is also managing the ICU. It will be difficult. The people, we will be thinking what happens to the patient. Is the doctor is seeing good or not? Are the nurses are attentive or not? The what happened to the patient vitals? It will be difficult. In ICU, you have to be continuously monitoring, and your phone will be continuously ringing. But in only emergency department, people only working in here, there will be complete switch on and off. At morning at 9 o'clock, if the person is going completely on, he can't do any other things like family time, house calls, or having a peaceful lunch. There might not be any time. And after 5, it's completely off. After 5, the person can do anything. That's what I like. Another pro of the emergency department. For other departments, it is not like that. We have to monitor everything, that duty doctor is doing good or not, that sister is doing good or not, what are the expenses of the patient, is the patient is staying in the hospital or leaving in the hospital, what the marketing team is doing, what the administration team is doing. Everything we have to be cared of. But in emergency, you are free of all that off duty.
Yes, sir. So, And sir, always there is this overlapping between branches, and more rightly so in emergency branch. So there are anesthetists who do fellowship in critical medicine, or DM in critical medicine, or pulmonary medicine people, or even general medicine people can set up their own ICUs and can give tough competition to emergency physicians. So what do you think about this competition?
Actually, there is no competition to emergency physicians. This is a misconception that emergency physicians will work in ICU. No, emergency physicians don't work in ICU. Anesthesia people are the kings of OT.
Hmm.
Emergency physicians will be in ER, and the intensivists, the critical care specialist, will be in ICU. The medicine people will be coming to ICU after fellowships. Pulmonologist will be coming into ICU, and pediatricians also will come into ICU. But they'll go into ICU, not in the emergency room. See, I can't full-fledgedly work in ICU because I'm not an intensivist. So the intensivist may not work completely in OT. The anesthetist may not completely work in ER. It's more than you see, because we'll see that many of the duty doctors only manage. Even now, 90 to 95% of the casualty or so-called emergency room is managed by duty doctors. We'll think that only duty doctors, they are not managing. Actually, they are like shifting the cases, they are taking the history, they are thinking that which department it will come, and they are moving the cases. Most of the care will be happening in the ICUs. That is not the part where the actual emergency department exists. We'll stabilize the case, we'll collect investigations, we'll near diagnose the patient, because pinpoint of the diagnosis, it might take days also for some kind of patients, like autoimmune patients or any patients like that. It might take days. So any kind of procedures, some orthopedic case is coming to me, a person is having a anterior shoulder dislocation, I will not call an orthopedician. I'll give the procedural sedation with the help of my team, my nurses and all, and I'll reduce the dislocation. I'll send the patient to a check X-ray, and after that, before shifting, if the patient is needing admission, I'll call an orthopedician. Then I'll tell that I'm shifting a patient to the ward, and he'll come. And if a case of femur fracture comes and he is in shock, I'll start the resuscitation. I'll try to increase the BP, transfuse the blood products, and finally the femur fracture has to be fixed by an orthopedician. Then I'll call for an orthopedic help, because the internal fixation, everything should be done in an OT. I can't go into the OT. So then the orthopedician will come for a help and take the patient from here. So no other department will come in resuscitating part in the ER. They'll come for assessing, reassessing the patients before taking to their departments. So anesthesia people are not trained in treating trauma, OBG, and pediatric cases. They'll be trained in things of medical, mostly medical, and they'll treat the stable cases, because if the patient is unstable, patient won't be coming into the OT, because patient have to be stabilized to come into the OT, and in OT only anesthesia people can see. And nevertheless, I'll know some intubation techniques, and anesthesia people also will intubate. Anesthesia people will know like more than 10 types of techniques to intubate, but in a safe environment. I know only 2 to 3 techniques in an unsafe environment, because in
Hmm.
a crash intubation, immediately in the chaotic environment, as emergency room is a open environment, anything might happen. So person have to learn to intubate a person in any kind of situation. So I can't do duties also. Some people will think, suppose in some MD departments, pulmonology or medicine people, they'll see IC duties. I can also see IC duties. But the vision of a primary specialty person to see an IC duty is different from an intensivist, trained intensivist. Either you take fellowship, FNB, or DM critical care. Their total view is different. If some primary specialty person is reading 2 to 3 protocols for something, example, suppose pancreatitis, in critical care it is more than 10 protocols. That is, critical care is totally extensive. You need more patience and monitoring, which I don't have, which most of the emergency physicians don't have patience. We have zero tolerance. Any small or mild mistake will just burn out in the department. So everything we'll see to the utmost care in the department for some hours. We stabilize the patient and we'll shift to that.
Yes, sir. So thank you for clearing my misconception in a very detailed way, sir. And sir, what about the future aspects? That is, in super spec. What are the super specialization options after it, and what are the other fellowship options after MD emergency medicine?
Presently, as NMC, with the NMC guidelines, there is only one super specialty, critical care medicine. That is a bridge to go into ICU. Not directly after residency you can go in ICU. That is one super specialty. And in some departments, in some colleges, deemed colleges, there are other medical facilities also. Emergency physician can go into genetic medicine, oncomedicine, which has been recently opened in PGI. So these are
Okay.
the only specialties, super specialties. Main thing is a critical care medicine.
Yeah. Okay, sir. Fine, sir. So the counseling of this NEET PG 2021 is around the corner. So, what do you think are the things to be considered that for a aspirant of emergency medicine to look for in the college or hospital that he or she wishes to join?
First of all, I gently tell them to go to a established emergency department nearby you and work like you have joined the department for at least a week. Then they'll will go to know the scenario actually they can work or not. And after that, coming to counseling, if they are already fixed, they want to do this department only, there are several options. There is an MD emergency medicine seats which are more than 100 in emergency in India, and DNB seats which are more than 300. Now it is coming up to 500 and 600 due to increase sudden surge of the seats. So the difference between MD and DNB are administration. In MD you will get administration as a bonus. In DNB multiple facility managers will be there which will take care of the patient. You know, no need to go to manage the patient when the patient is coming, is he affordable or not, because if the patient is affordable only he'll enter into the hospital, otherwise he can't enter into the hospitals, corporate hospitals. Everything the people, separate departments will have department managers, they will take care of other things. But in MD, administration will come as a bit added bonus. And coming to the exams, DNB exams are more tough. The pass percentage is little bit less than MD. So it is like when you want to, I prefer MD because it is not a completely established department like you take medicine, surgery, or gynec. You have to go to another place. You have to set up your own department. With having no experience in administration for a DNB person, it will be tough. I'm not telling that they can't do. I know persons who can do well, but it should be they should be trained in the resident periods also. So for an MD, it will be easy because multiple times even the drugs, the crash cart, the inventory will be checked by the residents in MD. In DNB, many of the administrative things will be taken care of the management, the corporate hospitals. So they don't know that they should look after this. That is the only difference between MD and DNB. And academic sessions, MD, if in an established department, they will be morely concentrated on academic sessions. In DNB, it is less. People have to study on their own, otherwise, it's difficult. So many people in MBBS, they used to be spoon fed from their seniors or parents, or they'll read in the last 1 or 2 months. In DNB, if for that kind of persons, it is tough because no one will be behind you. They will run their duty and you have to study on your own. And there is a new thing, DNB in government hospitals. For any other department, I'm not commenting. Only for emergency department, if there is no faculty, it is better not to join, because without faculty, whom will you follow or who will teach you, who will give the academics. Even in MD, DNB, in established departments only, it is very tough to cope up. For a new department who are not actually emergency physicians or not actually interested into this emergency medicine, they might not do well in that 3 years. And after they come out, people will see them as an emergency physician and they will not able to do anything. So that is a bad thing. And even I scold my juniors because of only this point. I don't want them to shine or they to perform well. When they go out, when they are establishing a department, when they are seeing a case, the good point, the positive vibe should come to an emergency physician. Okay, this is emergency physician means this is what he can do. So further, I'll prepare. And even I'm an ACLS instructor. So when I sign my providers, when I sign on their cards, if they are not resuscitating a patient well, if someone goes to see their cards, my sign and my name will be there. The blame will come on me. So I will be stringent. I'll try to try them to teach, learn, and everything.
Yes. Okay, sir. So, at the end of the interview, I would like to say that it is very, very kind of you and of a person of your stature to agree with us and have an interview session with us. And you are very humble for a kind of degrees you have and the experience you have. And I am very, very inspired by you, sir. And sir, is there a kind of any special message that you want to add?
Special kind of message means you have to be passionate. Not even in the residence period. After coming out, also you have to be passionate, and you should have an empathy towards a patient. I even scold like I'm humble. You are looking at me outside of the department. Every emergency physician will have two faces, inside here and
Mm.
outside here. I'm outside here, so I'll be humble. There is some
Okay, sir.
question. Can an
Yes, sir.
emergency
Any of the okay, sir.
question from Rahul?
Many people have joined, and I think Anushtup has a question. Anushtup, can you write it, or you can also turn on your video and ask it?
Yeah, the question is, can an EM doctor do PCI?
Yeah.
Uh, Hello, Anshul. No, emergency doctor won't do PCI. But until the patient goes to PCI, everything will be managed by an emergency physician. For suppose a call comes from a nearby town or village, we have to send our ambulance with a trained technician. He'll go there. He'll take an inside ambulance ECG. If needed, he'll give antiplatelets also. And while that patient is coming to emergency room, I'll activate the cath lab. So everything, every corridor, there is something known as green corridor, will be ready for the patient. Immediately after the patient coming in, my clock will start ticking from zero, T0. Within 10 minutes of time, if the ambulance is not having an ECG facility, whatever might be the patient condition, within 10 minutes, ECG will be done. So within 30 minutes, if the patient is fit for thrombolysis and my hospital is not having a cath lab, I'll thrombolyze the patient for a STEMI cases, I'm telling. And if I'm having a cath lab, I'll shift the patient immediately to the cath lab. The waiting period is 90 minutes. That's door to needle is 30 minutes and door to balloon is 90 minutes. 90 minutes is the max, but for an average time, it will be 40 to 45 minutes in my department to shift to a percutaneous intervention. And meanwhile, if the patient is having an arrest, VT, VF, will shock the patient, will resuscitate the patient, will intubate the patient. And even if the patient is having any septal rupture, pericardiocentesis, pericardiocentesis also will be done. Tamponade will also be treated by emergency physicians. And cardiologists won't be doing pericardiocentesis. CTVS surgeons will be doing. And that is also in the safe environment, in the OTs. So we are trained to do this kind of pericardiocentesis with or without ultrasound in the emergency department also. I have done a quite pericardiocentesis in my department. Not even surgeons are trained to do. We are trained to do that one. So we stabilize the patient and we'll shift the patient to a PCI. So the patient will have that stenting process and will go to the cardiac ICU.
Yeah. Yeah, so Sir Anushtup has also thanked you for this wonderful session, and he has also asked that if you can name any good institute for MD or DNB emergency medicine.
Uh, there are many institutes. If you are having a names, MD emergency names, you can go into any aims. And likewise said, Kerala is the top literature in the country. In Kerala, you can join any emergency department because Kerala is already developed. Whereas other states are having emergency medicine as a developing department. In Kerala, you take any hospital or a college, the department is already established because most of the emergency physicians are concentrated in Kerala and different parts of AIMS. And you can see the previous history of the department when the department has started and when the PG course has started. If it is enough for a department to have 3 to 4 years of PG training to call it an established department because the PGs who are trained there will be becoming the SRs, assistant professors there only most of the times. So there will be emergency physicians. You will learn under an emergency physician. There will be a difference between learning from emergency physician and others. And I'm not looking down onto another departments. I am having faculty from general medicine, general surgery, anesthesia, OBG. Every one form a group in emergency medicine faculty. And the main person who is teaching the floor management is emergency physician. Either he can be a senior PG or an SR or a newly joined assistant professor. But the main faculty professors will be from outside departments who are interested to do care for this emergency medicine. My basics are good because of my anesthesia professor. So my surgical skills are good because of my surgery teacher. My kind of diagnosis, differential diagnosis is good because of my medicine professor. So you will have an opportunity to learn from all these professors.
Yeah. Okay, sir. So this is kind of the end of the session. I don't think there is any other doubts left, as you have covered everything in almost everything in every detailed manner and in a very beautiful way. And so, thank you very much, sir.
It's my pleasure to attend this one because I want the department awareness to grow because many people will look down to the emergency department. Oh, what they will do, it's not their mistake because they haven't seen a established department. So whenever anyone is having time, you are free to enter any emergency department with a permission of the HOD, and you can go, you can watch actually what they are doing. So I'm happy to have this interview. Thank you. You can contact
Okay,
me
sir.
anytime
So, okay.
in Instagram. The name is The Emergency Doc, Ravi Teja Kethavath. Thank you, guys.
Okay. Okay, sir. Thank you very much. Thank you.